Good morning, everybody. My name is Henry Elphick. I'm the CEO of LaingBuisson. I'm absolutely delighted to open this webinar. The title of the webinar is Social Care, the Long View. And we will just wait for more attendees to join. We've had over 900 people register for this webinar. At the moment, just over 300 have logged in. It's climbing as I speak. Just to set the scene very briefly, from a LaingBuisson perspective, we've been spending some time building a coronavirus toolkit for people. And essentially what that does is it allows people to have access to information about coronavirus, news that's relevant, data that's relevant. So I'm just going to share my screen very briefly with you. This is our website, which hopefully you can all see. There is a tab here for the coronavirus toolkit. And essentially what we've done is we've brought together information that allows people to have headlines, links to good advice, support for charities. And the two charities we're particularly focused on are Turn to Us and the Care Workers Charity. And I really highlight that because whilst this is a free webinar, if you're able to donate to either of these charities, that would be hugely appreciated. Turn to Us is the Telegraph charity of the moment. They've raised about £1 million over the last few days. And Care Workers Charity is sort of linked with Turn to Us. 40% of the care workers that they help are referred to them through Turn to Us. And they're giving grants of around £500 to people, essentially to bridge the time between people running out of money and being able to access some of the government schemes to help them. Just in terms of where we are on coronavirus, we've got some live maps which show you here what the day count is of cases, the cumulative cases to date, the daily death count, and you can see that that has come off. So we've peaked at 980, it's come down, but it's also hopefully flattened. And then if you look at the cumulative death roll, you can see that's been going up. Interestingly, also, if you see where the concentrations are, so in London, Croydon, Southwark, Brent, and Barnet, higher concentrations, and then regionally, you can see whilst London's out in front, the Midlands are again, a very significant area with COVID-19. So from the LaingBuisson side, what we're trying to do today is very much focus on what's happening at the moment, and we've got a fantastic lineup of panelists to do that. But also we want to focus on the future as well. So this isn't just about what is happening day to day out there at the moment, but it's also what the future holds, and hopefully some of the positive changes that come out of this pandemic, particularly for the social care sector. And I think we've seen some very positive moves already in terms of our Secretary of State for Health and Social Care wearing the care badge, and I'm sure Martin will touch on that. But more importantly, I think it's also an opportunity to really make a systemic change for the sector. So just to set the scene, we did a Twitter poll where we asked people, how will social care change after coronavirus? And what's interesting is that there is clearly a focus on technology is making a big difference, more digital delivery. And we've got some people in the audience who are experts on this. And I think this has been particularly obvious in primary care, where remote consultations have been happening. There is 25% felt there would be more integrated care. And we've seen some significant and very swift movement in terms of bed blocking and the NHS placing elderly people into care homes. We've seen a much smaller view that carer status will improve. And then I've got to say nearly 20% think that we will just revert to where we were. Now, because we've got so many people on the line, in order to manage the Q&A and the polls more efficiently, we're going to use Slido. Slido is a tool which you have to open in a separate device. So if you've got a mobile phone, a smartphone, a tablet, or indeed your computer, if you go to a browser and just put in slido.com, this will bring up a page, and you'll see that there's a box to put in an event code. And the event code is TLV. It's in the top right hand of all the slides as well. And if you put that event code in, you're then able to ask questions, either anonymously if you wish to, or you can name yourself. And then I will be able to moderate those questions to the panel. In addition, we can also run polls. So I think we're going to experiment with that by effectively rerunning that Twitter poll. So if I go to the next page, you can see here is the poll. I will make the poll live and activate it. And this poll will be running during the course of the next hour and a half. And I think it'd be very interesting to see, as we discuss things, and you can revise your polling, whether this poll actually matches the Twitter poll that we had, or whether people's views change as we discuss some of the key topics. So 70 of you, 80 of you have already logged into that. That's fantastic. I will let that continue to run in the background. So in terms of some of the questions that people submitted ahead of this, I think there's clearly a lot of focus around PPE, integrated care, the reset on the perception of social care relative to the NHS. I think some specific questions from a practical side of things around whether care homes can run on a skeleton staff, what is the tipping point, the impact of no CQC inspections, does NHS block booking at premium prices relative to local authority prices offer some upside to the sector? We've seen actually occupancies holding up very, very well at the moment. But how is that going to last if coronavirus rolls out across people's homes? And how well can providers manage coronavirus? Because somewhere between 50% and 2/3 of homes appear to have service users in the home with coronavirus as we speak. I think some of the other questions have been very much also looking at the outlook. So we had one question really around the financials of this. If the housing market has closed down, if you can't sell your house, and then therefore you can't fund private pay, what does that mean in terms of outlook for the sector? So in terms of our speakers, I'm really delighted we've got such a fantastic lineup of speakers. The running order and the structure of this is that each speaker will talk for 5 to 10 minutes, and we will then open it up to a broader debate where I will take your questions and direct those to the appropriate person. So we're going to start with William Laing to set the scene, and also feedback on some of the survey data that we have been getting in the last few days. Chris Day, who's the Director of Engagement at the CQC, will then cover it from the regulator's perspective. We then have Pete Cowley, the CEO of Barchester, and James Thorburn, CEO of City and County, to cover it from a provider perspective, looking at elderly care and at home care. And Pete was on Radio 4 this morning on the Today programme, talking about some of the challenges the sector is seeing. We then have the associations, so Martin Green from Care England, and George Tuthill from Oxfordshire Care Homes Association. Martin in particular has been extraordinarily active in talking to government, to Public Health England. And then we're going to have effectively the commissioner perspective with Ian and Kathy from Hertfordshire and Berkshire respectively. So on that, I will turn over to William to present some of the findings from the survey that he's been doing over the last few days. William.
Let's get rid.
William, you're on mute.
Okay, there we are. Okay, thank you very much, Henry. So we've done a survey in the last couple of days very rapidly, and I'm glad to say that we got a pretty good response from care homes. Not quite as a good response from the home care groups, but I think that reflects the extreme fragmentation of that sector. So I'll go through the results in 3 slides. The first one looks at the coronavirus deaths to date outside hospital as a percentage of service users. So for home care, you'll see a 0%, and then 1.4% for care homes. One of the interesting things to me was coronaviruses to date as a percentage of service users, where we have 6.8% in care homes and just 2.4% in home care. So what this seems to signify is that the recipients of home care, as I suppose you'd expect, are more shielded because, of course, they did not, just prior to shutdown, they didn't have the same number of visits, obviously, to where they lived, whereas care homes did. So, but I think that's quite an interesting point, much lower rate of infection, according to the reports from the major providers in home care. And then another interesting thing, this part partly is cut off, the frontline staff unavailable for work. And this interesting, it was interesting to me because I was expecting a much higher percentage of frontline staff unavailable for work. In fact, it turned out from the reports of the major providers that we have that, the figure is 12% unavailable, which means 88% available for care homes, and then 85% available, 15% unavailable for home care. And that's a somewhat lower and reported unavailability than I expected. And it shows that, that the whole system seems to be more resilient than perhaps one might have expected it to be. So if we can go on to the next slide, this is the key number which may well be picked up by the press later. We extrapolated from the results we got, and the results, the capacity of the providers that reported to us was about 13% of total capacity. I see no reason why the reporters should be unrepresentative of the total sector, so we've simply extrapolated on that basis, and we get to a figure for the UK as a whole of 5,300 deaths to date outside hospital. And as you, of course, you know that the number that's reported in the press and by the government is just people who are deaths within hospitals. And that's running at about 11,000 at the moment. So what this seems to indicate is that these figures are correct, that about half the deaths are taking place in care homes and compared with in hospital. How does this compare with other countries? Well, we have higher rates of deaths, or higher proportion of deaths reported in other countries. But interestingly enough, we've done some recent work looking at the relative rates of care home usage in this country versus other countries, certainly in Northern Europe. And of course, they do have many more people in care homes than we do have in the UK. So that might be a partial explanation for that. The home care number here, of course, is 0 because we simply wouldn't expect any deaths from coronavirus in people's own homes. So if we go on to the next and the last slide, this is simply the adequacy of PPE. Now, the care home operators, 2/3 of them reported adequate PPE, 50% of home care providers. But what they did emphasize is that very often this isn't because it's been distributed from official sources, but in fact, a lot of operators have simply used their own resources, sourced their PPE in different ways. So these are some numbers which I hope will sort of set the scene. But I would sort of reiterate what Henry just said, is that what this is about is the long view. So I think these are interesting numbers, but let's hope we can, in the course of our discussions, focus also on the medium to long-term view as well. Thank you.
Thank you very much indeed, William. And now if I could turn to Chris, Chris is the Director of Engagement from Care Quality Commission. And the CQC have been extremely active over the last few days in the sector in terms of instigating a lot of the testing. So Chris, over to you. Oh, I think we just need to unmute you.
Oh, can you hear me now?
We can.
Thank you for that opportunity. Just what I'm going to say is probably very similar to what other colleagues are going to say around the country. We've over the past probably last month, we've been talking to care home providers and stakeholders, and there are probably 3 or 4 recurring issues that are important for us to do. Rather than put all the slide out, and I'll just talk to a number of issues if that's okay. So as William said, adequacy of PPE, and obviously we work across both the NHS and adult social care, and I think it's fair to say that the coordinated response that's been to some degree shown in the NHS hasn't at all matched the response within adult social care. And one of the things that we've been doing with colleagues in central government is trying to get a better picture nationally of the PPE shortages in adult social care, in order that we can make sure that it's built into the supply chain thinking for future demand. Added to that, the issues around both testing of colleagues and the movement of people from health to social care, and the exposure that places on care homes and residential care settings are probably our 3 biggest issues. We also know from our work on a market oversight scheme that the financial reality of adult social care providers who may now face a shortfall in their income. And we've also picked up, along with other colleagues, the disproportionate impact of the BME communities, particularly staff in BME communities in adult social care. So we've been looking at those 4 issues, and probably with other colleagues on this call, trying to get some coordinated action. With regards to, if you can move up to my next slide, with regards to testing of colleagues. Move on to the next slide.
Oh, sorry.
It's all right. So last Thursday afternoon, we were in conversation with Deloitte and the DHSE. Deloitte are running the testing centres on behalf of the NHS about capacity, and whether or not we could begin to use some of that capacity to support testing in adult social care. So late Thursday afternoon, we were given some of that capacity initially in 3 sites, though it's grown to 12. And what we want to do is make sure colleagues who work in adult social care have access to testing. Now, in some cases, organisations are part of agreements through the NHS or part of agreements through local authorities. So we had no intention of cutting across those, but where colleagues weren't able to access testing, we wanted to make sure that all colleagues who work in social care at the front line of care had that access. When we began the work, and thanks to colleagues who are on this webinar link as well, we've now reached out to about 12,500 providers, including many of the corporate providers who provide care. We've sent for testing as of this morning just over 6,000 colleagues. So it's a small thing, but it's important that we can get the right testing available for colleagues who work in adult social care. We'll continue to work with local authority colleagues where I think there's some of the arrangements in place in some areas, but I suppose for me it's just about the speed of access to that testing, and if we can continue to support that, we will. We'll also look to how we can support it in other areas as well. So we've particularly focused on residential nursing and domiciliary care, but we will look to provide support to other sectors as well, particularly those who can't access easily the NHS route for testing. PPE and supply. So what we've been doing here is we're working with the NHS colleagues around where there might be supply shortages. So there's a document called the Nhs Tracker, which is used by adult social care colleagues, and they complete that to give a picture of, amongst other things, supply of PPE. We've launched on Monday a similar service in domiciliary care, for which we're rolling out over the coming days. The idea of that is basically to give people at the heart of government a clear sense of where PPE is short across the country. So our aim for this is to provide some sort of heat map that gives a sense of where PPE should be directed, so we can make sure the logistical supply chains that are in place for the NHS and are beginning to work also work both in quantum for adult social care colleagues. It isn't just a question of sending a few elements of supply to each provider. There will be parts of the country that are particularly short, though I think, to be fair, all parts of the country are short at the moment. We've also been talking to colleagues in government about testing for service users. So, I'm sure providers will talk to the same issue. People moving into residential or nursing care from the NHS, there is a big concern about whether or not those colleagues might be carrying a virus. And so we've been working with colleagues in PHE to roll out testing for people moving between the NHS and adult social care, or anybody moving into adult social care, as well as the testing of people during an outbreak. And I think there's with some effort, there was a movement yesterday to make sure that all service users where there is an outbreak will now be tested, which is great news. And crucially, anybody coming into an adult social care facility should now be tested. The logistics of that and managing that, I know PHE are. I just left a call before where they're looking to manage that and to support that. And from our perspective, it's important that we can provide the right information to support that testing program. Which sort of brings me on to my last point about information and data sharing more generally. So we have lots of information for the nature of who we are, both in the NHS and adult social care. I think it's important we can use that information to guide national support organisations to provide support to the right providers at the right time. The other thing we can do, we have a lot of people, we've got a lot of our own staff that have gone back to the front line in both health and care. But for those that remain within CQC, how we provide support to providers who are having to make difficult decisions around things like the Care Act easement or what that might mean for individual service users, it's important that we can provide the right support in the decisions that they make. So we're trying to provide more of a responsive service where we can talk to providers at any time, listen to what they're trying to do around managing a particular situation in their area and provide the right support. So this is not inspection. This is about providing support and advice to registered managers in local areas so that they can take what we know will be difficult decisions in the coming days and weeks. Those are the 4 areas I wanted to talk through. Happy to take any questions or comments.
Very good. Well, thank you very much indeed for that. I think at this stage, what we will do is actually segue nicely onto the providers. So I'm going to ask Pete Calverley to talk first. And Pete, as I said, was on the Today programme this morning, but was also speaking yesterday about, I think it was 400 beds you said that you'd filled from hospital discharge. So Pete, I think people are obviously very interested in what is happening at the moment, and you're one of the largest providers in the country. But equally, I am very keen to focus on what changes as a result of this pandemic for social care, and maybe your thoughts on some of the, hopefully the good things that will come out of this from a system perspective and the way that social care is perceived. So over to you.
Thank you. Is my presentation going up as well?
I don't think I got your presentation, I got to say, so you're freewheeling.
Okay, so just a little bit of, while this is, I'm sure, echoed throughout all providers, I wanted to give you to start with how it's impacted Barchester. We run 236 homes and have 12,600 residents and 17,000 staff. So I'd like to explain how it's impacted us, the problems we've encountered, the solutions we've come up with, and how they may then, as Henry said, point towards the future and how things might change for the sector and the interaction with commissioners. So first of all, in terms of the impact to date, we've had 196 deaths, which is 1.5% of our residents, across 32%, which is 75 of our homes. Of those, 66 died in hospital and 130, which is 1% of our residents actually died in our homes. We currently have 663 residents either with symptoms or tested positive. That's 5.3% of our total residents. They're currently being barrier nursed in 118, which is 50% of our homes. And we currently have 978 staff isolating, and 600 off sick due to all causes, which includes being sick with COVID. So that's about just over 10% of our staff are off for both causes. In terms of what problems we've come across, the pressures we're facing, so let me go through to that. First thing was, as soon as all the announcements about COVID came out, clearly a lot of people went off self-isolating or went off sick or were furloughed with the 12 weeks if they were sent the letter from for shielding from the government and the NHS. So with every one of these, clearly it's having an impact, and the 10% I described is not 10% on average, it's an average. Some homes it's less, and some homes it's significantly more, particularly those who are particularly affected. So in some homes, the pressure has gone up towards 20% of staff self-isolating and even more. So what we've done is made sure our HR department call every member of staff to ascertain the reason they're off work, and then fix a return to work date. One of the questions that came up on the text was, what do we do with the skeleton staff? Can you run a home? Well, we don't hope to get to that point, because when we have escalation points at a critical escalation service, that means we go straight through a process of escalation. We go look for our own staff to do extra shifts. We look to our banks. We look to sister home staff with or without shift incentives to travel to come to the homes. We look to agency, whether it's our preferred supplier or a next step agency that isn't on our supply list. We also, in some cases, have got local authority and NH staff offered to come in to 2 or 3 of our homes, which have been in a critical position with staffing. We use our own central support teams that normally do regional responsibilities. We've deployed those, some of whom are qualified nurses, some of whom have been home managers, some of whom would be administrators, and they've gone into homes where we've been short. And we've now, over the last couple of weeks, mobilised queries and questions on social media to recruit volunteers through Twitter and Facebook. We've now got 500 with DBS checks and going through completed basic e-learning that we've sent access to them. These aren't to come in unless we've gone to the top of the critical staffing escalation service, but at least we know the geography, that they've had DBS, and they've completed the basic e-learning. We've since written out to all of our relatives, over 12,000, asking them if they're prepared to volunteer, not just to look after their own loved one in the home, but also to look after, to take up responsibility for other tasks within the home. And we're getting a great response to that. Again, all of these people then have to go through DBS, which is quite rapid now, and complete a basic e-learning module, and none of them will be invited into the home unless a specific home comes under such stress that we've gone through all the escalation process. I think the recent availability of antigen testing that Chris mentioned, we've accessed 280 staff we've referred, and another 100 are on the way at the moment, Chris, so wait for them. And I think that's a great help, particularly as we can tell staff if they get symptoms or the family gets symptoms, you can get tested rather than going off self-isolate, or we just self-isolate for 3 days until we get the results. So that's great. The issue with everyone's having is availability of PPE. I think currently our supply chain has generally been resilient, but it's been patchily supported by government supply, and particularly some patchy support from the local resilience fora, where we've had some great results, sometimes 2,000 masks and gowns and so on coming, but in other areas they say they haven't got anything or they can't supply it with us. So it's a bit patchy. It was good to hear the Minister, Secretary of State saying yesterday there will be another way of accessing direct supply through the Royal Mail, or delivered by the Royal Mail. I don't think this has been helped in terms by this ever-increasing specification of PPE guidelines, which is fair enough for learning from the evidence. I think that's fine. But actually, on top of that ever-increasing demand for us to use more and more PPE, quite rightly, we've also had local maverick interpretations by some local authorities, CCGs, and health professionals, where they've come up with their own decision on what protocols should be in place and what extra PPE might be required. And we've had to push back on that quite hard. As I said about the availability of testing, it's very frustrating because, and I do think the changes announced yesterday, if they can be delivered, are great, because it will help us, as we all know, in terms of determining which cases are COVID positive or not, which of our staff have the illness or not, and the testing of residents coming from hospital, patients coming from hospital, is a great step forward, although I see in the guidance that actually it says those who are still tested positive, there may still be a request to place them in the home under certain protocols. So that's not quite been the best of news, because there's obviously some flexibility in that. In terms of what's happened with the lockdown, we started a week before the government. We stopped all non-essential visits, including our regional teams going around through homes, stopped all non-essential refurbishment works. We have weekly calls with our general managers, over 300 people on the call with Q&As. We have a helpline for all our, which has been really supportive. It's a helpline that's 24/7 for any queries from our home teams, from relatives, from staff that come in about PPE and our policies, how they report, daily tracking of cases, etc. And it's been a real step forward for us. In terms of our relatives, they've generally been very supportive, but I have to say there's been, particularly when we locked down a week before everybody else, or a lot of people, we had some pretty difficult conversations with relatives. I think now it's going generally well. We've had one step forward in terms of looking to the future, is that all the homes had Wi-Fi, but not all of them were regularly using Skype. But we have tablets now in every home where Skype's used with a booking system for all relatives to book a time they can Skype with their loved ones in the homes. And that's been working really well, and we've had some fantastic feedback, and that'll be something that we definitely keep going through the future. As I said, we've got the coronavirus helpline, which works very well for relatives, and we send a letter to every relative every week, an update about what's happening in the business, what's happening with government policy, what's happening within our homes, and that's been very well received as well. In terms of looking to the future and what we've changed, we've our normal audits where we go in every month doing audits of every home has obviously had to stop because we stopped our regional teams going in. So we've developed online ways of doing observation of the central action plan, and every regional director contacting the homes to make sure they're progressing with the central action plan related to their quality issues they may or may not have had before. And that seems to be working well, but the proof will be in the pudding when we finish the lockdown and CQC start inspecting again and we start inspecting again. But that's been quite an interesting development. In terms of recruitment, which also could be a good thing for the future, as well as that encouraging message from the Secretary of State, where he said they will be supporting us with the cost of induction of staff and in supporting, promoting care sector workers in applying as care as a profession. We've actually had a record number of applications for care, kitchen, housekeeping, admin, maintenance, obviously with other sectors closing down. But our application rate has gone up by 50% across most of these different areas. And we're now doing, instead of face-to-face initial interviews, we're doing online Skype interviews. Thankfully, the fast-track DBS is working very well, I think. The truncating referencing system, where you apply for references, and if you can't get it because the people you're supposed to get a reference from are at home and not at work, you just put a file note in, which has been great. We're now sending e-learning inductions out to new starters before they start while we're waiting for references in the DBS. And I think that's something looking forward, we will definitely need in the future, rather than have them doing the learning once they start in the business. And we are paying them to do it at home before they start, and observe practice once they start by Skype from our trainers. So I think that is something definitely going forward in the future, is a much more efficient way, and it's worked very well. And we got it up and running, and the new e-learning modules up and running very quickly. And we've moved from an operational trainer model in terms of training to an extended e-learning plus observed practice, as I described, for ongoing refresher training. And I think that's working very well as well. In terms of some other positives, we're coming up with a lot of innovative solutions and new ways of working, and we will probably lock those down, not only the home-based solutions, but also the way we work as a management team and as a corporate team with meetings. We've had using Zoom like mad, and actually it works very well, and we're going to have a lot less people coming to head office for meetings in the future. And as Henry also said, we've got nearly 400 block contract beds across 30 services, with another 200 more in negotiation. And in terms of looking to the future, a lot of people on the calls will know we've all been working for years on trying to get more integrated services, and the use of our capacity in partnership in health and social care communities to relieve winter pressures with step up, step down beds discharged to assess beds and so on. And it's been like pulling teeth to actually get anywhere with that. And suddenly, within a couple of weeks, we've negotiated 30 block contracts, and they're all working really well. The relationships with the commissioners, local authority, the NHS, how it works, has been in most cases exemplary. And if people can do that in the face of a crisis, this must be a blueprint for how it can work in all those black hotspots for delayed discharge across the country every winter. Why can't this way of working be promulgated in the future? And in terms of the other important thing, which I think the Secretary of State mentioned, there was actually raising the status of social care and social care workers to alongside and parallel of that of the NHS. I think that's down to us, not only for government to do and the public to do, but in terms of how we react as employers to that, both to encourage recruitment and retention, is to act as a great employer. And we've, for example, when people go and self-isolate, we've given double statutory sick pay for those self-isolating. Anyone who's ill with COVID, we give 80% of their salary rather than sick pay. Anyone who's shielding, we're giving 100% of salary to all the staff. And at the end of this crisis, we're going to give £200 or £250 to every one of our staff to thank them for what they've done. And I think that sort of thing, as a good employer, puts a message to your team when they're under absolute stress, and some of the homes are under critical stress. It actually says, we're supporting you. And I think that's a good thing. So I'd probably like to probably leave it there, Henry, unless you want me to add anything else. But
no, Pete, that is incredibly helpful. I think just to sort of summarize it for everybody in terms of the outlook, there were sort of, I think, 3 themes I picked up there. One is around different working patterns, the way you work both as a management team, the way you recruit people with e-learning, etc. So there's a sort of, in some ways, the pandemic has been a stimulus to change the way you do things, and a lot of that is driven by technology. There's the block contracts that you've been able to sign up, and therefore actually the pandemic has, through necessity, has actually done what we've been trying to do for some time in terms of bed blocking. And then the third element was just around recruitment, which goes to people's awareness of social care, the improved status of it, and their availability to work. I guess the big question is how much of that will stick after this, and maybe we can develop that theme later. But thank you very much indeed, Pete. What I'd like to do now is turn to James Thorburn, who's the CEO of City and County, who are the largest home care provider in the country. And I think there's always sort of a pecking order we've seen where it's gone sort of hospitals, care homes, home care, in that order. And James, would be very interesting to get your perspective as somebody who's seeing what's going on the front line from a home care perspective, which I think we've already seen from the data from William is a different picture. So over to you, James.
Thank you. So firstly, City and County Healthcare, we provide community-based care to people in their own homes. So we don't do any care homes, we do extra care facilities, but we're focused on care to people in their own homes. We started about 10 years ago, and we've built over those 10 years to be the leading provider in the country. We are looking after at the moment around 27,000 people, and we're doing around 60,000 community visits a day, and we have a staff of around 14,500 people in total. So in terms of the data picture, we see something very similar to what William said. We've got about 3% of our service users, people we care for, are self-isolating or confirmed with COVID-19. We've had about 50 deaths, sadly. Thankfully, we haven't had any staff deaths at the moment, although there are a couple who are receiving intensive care at the moment. Staff absence is around about 10%. And we're seeing around between 5 and 10% of people actually refusing care at the moment. Now, what I think is interesting about that is, so the 10% of staff absence, we are coping with that. That's 10% above normal staff absence levels. So there would always be a sickness or a holiday pay absence. And we're coping pretty well with that. And the reason for that is because of the flexibility of the workforce. The average carer does about 26 hours a week across our business, and that can flex up and flex down, particularly in times of crisis. And most of our branch and back office staff, certainly our branch staff, are trained to provide care and therefore can step in. So there's a lot of natural capacity flex. We are seeing actually reduced care levels, which was a surprise to me in the community. As I said, about 5 to 10% down, and that's not being driven by staff absence. Actually, we can cope with that with natural flex. What's driving that is actually people who are fearful and frightened and don't want other people to come into their home, or friends and family, I think, who at this point in time are a lot of them are not working or are able to provide care to people. So I think we'll probably see that, given the pent-up demand for community care that's unsatisfied, as people go back to work and as new assessments start to flow again. I think we'll probably see that bounce back pretty soon after this. But I think that, you know, people are very scared and very frightened out there. The main issues, I won't go through, and Pete gave a fantastic account of everything that Barchester is doing, and suffice it to say, we're doing some very similar stuff. What I would share though is PPE is a massive issue for everyone, and at present, the supply lines simply aren't working, and there are two aspects that are problematic. We had one person spend 2 hours to the 4 designated wholesalers in the government supply chain yesterday, who managed to acquire 1,000 aprons in those 2 hours. I said we do 60,000 community visits a day. The numbers here are much, much higher. And we also used the National Supply Response line as well, and got an order of 100 out of that after quite a while trying to get through. So it's simply the volume of PPE here is the problem. And I think there's a problem also with the inconsistent interpretation around the guidance, which has been really problematic. And that's happening with doctors, nurses, that's happening with local authorities. The shielding category seems to be growing rapidly with doctors prescribing. And I think that is a real problem. If you're in a lifeboat and you don't know how long it is until you're going to be rescued, it doesn't make sense to go through your food quickly. And that is where we are with PPE at the moment. And if we use it up now in lower risk scenarios, as some local authorities have asked us to do, what's going to happen is we'll run out, and that will stop care, creating much more harm is the fear. So I think we need to conserve our stocks and follow the guidance which we're following. We also are having to push back a lot on the system overall around the guidance of where we're using PPE. I think in recruitment terms, I very much echo, applications are up, and there's lots of great stuff like the DBS, etc., which has been fast-track DBS and adult first, which is really helping. But actually, it's early days on those new systems, and I think we're not seeing that flow right through to the front line yet. There are lots of operational challenges, I think, in making that happen, but I think that's a challenge to the sector and all of us. I think there's been a lot of talk on testing. That's very new, all of that. We're just not seeing that in the volume that we need at the front line yet. But we really welcome that. And there's the financial support to the sector. There's been a lot of coverage on that. I mean, we're seeing about 50% of local authorities who have, moving to block or planned payments. I think just a word on that, because it is really important. There are a lot of people who have started paying carers by minute rather than paying them on block. We just pass through the structure that the local authority pay us through to the carer, and we back to back that so that we pass on any advantage we would get or disbenefit. And what that means though is it's an incredibly pernicious approach where the carers are only being paid for the minutes that they spend in with someone according to the care plan. And I think that really is unacceptable generally. And what we are seeing in this crisis is it simply doesn't work, and people are having to back away from that and move to block payments, which we absolutely pass on through to the carers. I think there's a lot happening there, but it needs to happen more, and there needs to be more consideration given to that. But as I said, about 50% of local authorities are paying block planned, about a third are paying us in advance. We're still around about 20% are acknowledging our increased rates, 5% or 10%, but that fifth isn't really enough when our SSP, our statutory sick pay, and our PPE costs will be at least 5% incremental increase. So there does need to be more done there, I think, in a sector that has struggled. But let me talk just briefly about the sort of future and the long view. I think I'm obviously thinking quite hard about this at the moment. I think there are really 2 points that I'd like to make. When you think about these sort of crises, I think what you tend to see is that either the trends that were happening are accelerated or decelerated rather than necessarily completely new trends emerging. And I think you've also got to look at the fundamental drivers rather than the height of the crisis, if you like. And I think I always look at financial, social, and political drivers really to see what may change in the market. You know, and from a financial point of view, it's about chronic underfunding of the care sector and under-recognition of the care sector. From a social point of view, it's really been about the view of social care, and as you said, Henry, not understanding the role that social care plays in public health systems, I think, in the social consciousness. And I think care homes and I think the NHS get an awful lot more press and understanding than community care, even though we care for vastly more people. And I think what you've also got is, is a very uncertain political landscape going forward, which and who knows how that will unfold. And I think guessing is hard because of the lack of clarity, and a lot, I think, will depend in terms of reform on what you think will happen from a financial point of view with the financial pressure, social point of view, social view of care, of social care, and the political landscape. But a big thing here for me is that point. Social care is really overshadowed by the NHS. And I really welcome the government's announcement last night about a new care brand, which I can see behind Martin Green, thank you, alongside the NHS brand. I take nothing at all away from the NHS and the fantastic job that they do, and that care homes do well. But community care needs to be recognised too. We spend, what, 130, 140 billion pounds on the NHS, and that's on 100,000 beds. We spend 3 billion on 500,000 elderly people in the community, and by estimates, there are 1 million people that we're not caring for in the community. So 3 billion on 1.5 million, 140, 130 billion on 100,000 beds. Now, this is a completely inverted triangle. What happens in community matters to the NHS. And like social distancing, social care is crucial to protecting the NHS. And maybe with social distancing, we're beginning to understand that. We have an older, sicker population. We've got constrained budgets. We cannot afford to just plough money, especially with the latest forecasts from the Office of Budget Responsibility and the Chancellor was talking about. We cannot afford to just plough money into the most expensive place. What in operational terms is either, in many cases, the end of the line or the failure mode for the system is where you tend to end up. And we've got to think more about social care. Hospital and care homes, we're also learning now, actually can increase infection risk. So in a pandemic, actually going into a closed environment is incredibly hard and challenging to manage. And I think we may see a degree of fear about people going into hospital in pandemics and about their elderly and loved ones in care homes, because infection spreads in a way that it doesn't in the community. And we saw that in William's cases right up at the very beginning of this. And what we've got to do is think about the overall public health system. We've got to think about prevention and avoidance. and give carers and community care the right spotlight as part of that. And I worried a bit when I saw Boris Johnson come out of hospital, because the question for me is, and clearly after his experience, there will be a lot of focus on the NHS, and it's incredibly visual what we see in the news. But my question is whether community care is going to share that spotlight, or whether it's going to sit in the penumbra, or even worse, remain in what I think is the darkness. And I think if it remains in the darkness, I think that will be an incredible shame and a massive missed opportunity. Because in terms of one of my big second order impacts here, I think the opportunity for community care in the future is very much about technology. And we've been investing over £10 million in a multi-year programme in technology to try and unlock the opportunities in community care. That's going digital, that's clear digital record keeping, understanding what's happening in the community, that's AI and intelligent support for carers who are out there providing care and facing difficult situations. And this is also key to better population health management and actually population health understanding of what's going on and tracking what's going on in the community. And we shouldn't be focusing, in my view, only on the end of the process, but very much prevention and avoidance at the beginning. And I think technology and the unlocking the data that we have around that is a fantastic opportunity. And I don't know if that will come out of this, but if it doesn't, and if the recognition of social care doesn't come out of this alongside the NHS, then I think we've missed a massive opportunity. And in that light, I'm incredibly encouraged to see the announcements around Care, the new brand, and that the government have put out. But what I really need to see is I need to see that translated into action, because I'm not seeing it at the front line. So it's early days, I support it, but social care can't remain in the darkness, and we need an overall public population health response.
So James, thank you very much indeed for that. I think just to sort of summarize again the themes that you touched on the long-term view, the message was it's an acceleration of existing trends rather than new ones. It's around technology and digital, which will probably happen anyway, but may happen faster. And I think the outlook on the other three, financial, social and political, are all rather clouded. Hopefully there will be more funding for home care. That on the social side, that community care, the appeal of community care to people to work in it will improve. And on the political side, it's really down, I think, to the politicians, to this green paper, and to an understanding that home care may be the lowest cost setting, to make sure that we see that shift. I think there's an awful lot around that, the funding. We've had some questions around whether local authorities will revert to minute-by-minute funding after this, or look at block contracts, and I think also, whether actually home care can play a bigger part. We talked about some of the bed blocking, and on previous calls with Ian and Kathy, I think Kathy, you mentioned that Berkshire had been placing people in care homes out of hospitals because that's the best place to put them quickly. But actually some of them might be better in a home care environment, but it just takes more time to assess them correctly to work out which ones would work in a home care environment. So clearly home care has the opportunity to play a bigger part. But I think this is a good intro then to Martin Green. And Martin's been very, very supportive of that care brand with his Care England hat on. But more importantly, has also been very involved in talking to Public Health England, Department of Health, and really putting the sector's voice out there to counterbalance the NHS. So Martin, over to you.
Thanks very much, Henry. And I won't go and reprise all the things that were said so eloquently by Pete and James. And I think there are some massive challenges. And I think both Pete and James showed us the scope of social care, which tells us how enormous the challenges are, forgetting some of the stuff like testing, like PPE, like a much more coordinated approach to social care when you have a very diverse sector. And also, I think we should acknowledge that one of the big challenges is it's a very diverse sector, and a lot of it are very small providers. And I don't want them to be left out of this agenda. Small providers are really important, and we've got to maintain the diversity of the sector. But given the fact that all the issues that are current were so eloquently expounded by Pete, by James, and by Chris, I think I want to go on to where we are with the future and how we can make sure that some of the gains that we've made out of this crisis are not lost. And I think it's really important to recognise that if we're not careful, we will slip back. So we've got to work absolutely hard to make sure that social care, as James said, is repositioned and also recognised for the enormous contribution that it makes. I think there has been greater recognition of social care in the crisis, but I think we shouldn't underestimate the enormous uphill battle it's going to be to position ourselves as a part of an integrated system. The NHS has had 70+ years of public recognition, and it goes down to also some liminal stuff. So I look at my tele-guidance and I see 25 different fly-on-the-wall documentaries, and they're all based in hospitals, and they all have a narrative which is the staff are fantastic, and if there's any problems, it's because the government haven't given them enough money. And I think, James, you really showed us that actually there are enormous amounts of resources going in there, and we have inverted the pyramid, and we need to start thinking about how we change that. I think that the recognition also needs to be translated into a much more clear approach to how we use that recognition to recruit staff. It's really great to hear from both Pete and James that we're getting more people coming forward at this time, but we mustn't lose them when this crisis is over. And I think part of that is about our offer to those staff. Pete, that was great to hear what you're doing. It was really positive and upbeat to hear that as an employer, you're really showing your staff that they're professionals and you're supporting them through this crisis. We need that to be the norm. It can only become the norm when the recognition and the funding are there for our care services. So that's something that we need to really focus on when this is over. I think there are some really big things that we have got in terms of movement, and I think I agree with your analysis, James. You know, things have really just paced up in this crisis. There has been some innovation and creativity, but there's also been some really fast movement on some of the things that we wanted to do. So I'm really looking at how we, first of all, use technology and how that helps us to shift information around the system, how also it can help us embrace the productivity challenge. I was interested in what Pete said about how he's now going to adopt a lot of the technology solutions that he's had to adopt in this crisis and make them the norm in his organisation. And I think that is something that we all should think about doing. I think we've gained some real political credibility in this crisis, and we need to make sure that that doesn't slip back. One of the things I intend to do is I intend to do a bit of an audit around all the stuff that has improved in this crisis, and then make that our pitch to government when it's over. And when the inevitable public inquiry happens, we need to be really ready to show what social care did, but also to position social care really at the centre of an integrated health and social care service. And I thought that the points you made, James, about population health are really important here. This is about maintaining populations in the best way possible. I think the other thing that's come out of this is actually this false notion of somehow there's either residential care or there's community care is absolutely not true. What we need to realise is we need continuums of care, and people need to be able to be supported at different times in their lives in different services. So I think the sort of animal farm philosophy that's pervaded in a lot of local authorities, which says we don't like care homes. Well, what you're seeing in this crisis is the importance of care homes and what they're delivering. I'm also really pleased that this out of hospital process has started to work well. And Pete, you really showed us that. And what we've got to do is to make sure that's maintained. We've got to make that the model for the future, because we don't need people in hospital who don't need to be there. And we can have some really good facilities in social care that help people, re-able them, enable them to be as independent as possible. And you're so right, Pete, many years we've both been fighting that corner about how we get discharge processes much slicker and much able to be used. And I think we've got to make sure we really capitalise on what's happening now. I think there's some really interesting things around the transfer of information and how we're doing that much more effectively. And I think we need to hold on to that. I'm also really interested in how we also get a very much sharper approach to data collection. The 21st century is going to be driven by data and informatics, and we have to be at the very heart of it, not at the peripheries. And I think we've made some enormous strides within literally a few days, and let's not slip back on that. I think we've also got to recognise that, particularly in social care, there are people with very high dependent needs. And so what we need are some really clear ways in which the NHS supports social care providers. And also we need to look at this holistically. So it's about support to the person, it's about support to families and relatives, and it's about positioning social care as that vital part of a continuum of care. I was also conscious that a lot of people have used e-learning, and Pete, you gave some great examples, and we've got to really look at how we train, support, reward our care staff. And this crisis can be the foundation of a paradigm shift in how we see social care staff. They've shown themselves in this crisis to be absolutely top of the line professionals who can do enormously complex things in tough situations. And we've got to capitalise on that and make sure they're recognised. I think there's also some challenges that we need to look at about how we review some of the quangos and organisations in this system. So, for example, we have NHS England, we have Public Health England, we have Health Education England, we have the quangos such as colleagues at the Care Quality Commission, we've got Sky, we've got all these plethora of people. And yet when we needed to have an emergency response, we brought in Deloitte. Now, the question I want to ask is, why did we have to do that? Is it an issue about lack of capacity in the public sector, in which case we need to address that? Or is it an issue about culture in the public sector and whether or not they're able to be nimble? And do they have processes that are about outcomes rather than bureaucracy? And there are some tough questions to be asked, and we need to ask them in the aftermath of this crisis. But my final thing is also to say we need to have a review about what is local and what is national. And it is frankly ridiculous to have a situation where we've got a national body, Public Health England, and then we've got a range of local people making up as they go along the guidance. We need to have some clarity about what needs to be national and needs to be delivered across the system and what needs to be local. And what I would say about that is, when we're having a conversation about what needs to be local, let's have some justification of it, not just we've always done it that way. So there are going to be some big conversations after this, and we need to make sure social care is at the heart of them. But the final thing I want to say is holding on a positive, which is this crisis has brought out the best in everybody. It's brought out the best in the statutory sector, it's brought out the best in the independent sector, it's brought out the best in members of the public who volunteered. We've shown how our staff are absolutely amazing. We've seen how relatives have supported organisations that have had to, for example, restrict visiting, etc. And by and large, with a few exceptions, relatives have been really supportive. And I think we need to hold on to those positives for the future. Thanks, Henry.
Martin, thank you very much indeed for that. So again, just to sort of paraphrase a little bit what you've said, a focus on population health, a focus on what is local and what is national. You're planning to really bring together the best that we've learnt out of this and do an audit after it. And it'll be things like e-learning, training and supporting and rewarding staff, that paradigm shift you touched on. That continuum of care between hospital, care home and community setting, which everyone talks about, but hopefully this is the nudge we need to actually make it happen. And then I think the other one, we've got Chris obviously on the line around the various quangos and everybody responsible for a part of the problem, and whether it is a cultural or a capacity or a coordination issue, that someone needs to take the lead. I mean, CQC have been extremely good at setting up testing centres. I'm not aware that setting up testing centres was necessarily part of their original regulatory mandate. So the fact that they've had to step into the breach probably tells us all we need. So I think on that, I'm going to now turn to George Tuthill, who is chair of the Oxfordshire Care Homes Association, but also an operator, and has some slides to share with everyone as well. So George, over to you.
Okay, hi. Actually, I've retired as chairman now. So I'm George Tuthill. I run a family-owned nursing home, specialising in caring for people with dementia without the use of routine tranquilizing medication. The home was started 53 years ago by my father, who was a doctor. I'm an engineer with a commercial background. I was chairman of the Oxfordshire Care Homes Association for 26 years until last autumn. Before taking the long view, I'm going to quickly describe what I learned from talking to 8 homes in Oxfordshire yesterday. 50% had COVID infections, with a combined total of 17 resident deaths and 2 staff members who are seriously ill. A feature described by 2 homes was the speed of the infection. Everything was okay on a Monday, but by Thursday they had 7 deaths. In 2 cases, 50% of the staff were suddenly off for a combination of illness and fear. The fearful ones have started to return. Some staff were frightened to go back to their families as they didn't want to infect them, and so the home was providing them with alternative accommodation. 2 homes said the infection was brought in by their senior staff, who were coming in because of an overriding sense of duty, despite feeling slightly unwell. Despite having vacancies and being offered realistic prices, none of the homes were prepared to even consider admissions unless they could be sure that the potential resident was free from COVID. The lack of testing is a big issue that needs fixing quickly. Now for the long view. I'm going to start by looking back 26 years. The Oxfordshire Care Homes Association has been collecting occupancy and pricing data 2 or 3 times a year from every care home in Oxfordshire since 1993. The data is consolidated and shared with all Oxfordshire homes and with the local authority. Although the data is Oxfordshire-centric, I hope you'll find the information interesting and help us think about our future. We send out an email that asks 4 key questions: the capacity of the home, the number of beds filled, the number of local authority funded residents, and the price range. About 20% of the homes respond to the email, and the rest we follow up with a phone call, and we normally get 100% complete data, 100% complete data set. All of the information provided by the homes remains confidential. We group the homes into 4 types: long-established residential homes, long-established nursing homes, and new homes built in the last 15 years, and other homes operated by the Orders of St. John. The homes are grouped into the 5 council districts. The slide you're looking at now shows the occupancy over the last 26 years of the group of long-established nursing homes. You can see how very stable the occupancy is at 90%, despite an increase in capacity. Next slide, please. Oh, yeah, it's there. This slide shows the occupancy over the last 10 years. The orange line is the long-established nursing homes. The blue line are the long-established residential homes, and the grey lines are the newer homes built in the last 15 years. Occupancies range between 85 and 95% for long-established homes. Occupancy in the newest homes fluctuates more, which is not surprising, as 150 new beds can be opened within a couple of months, and they take time to fill. The 5th slide shows how the data is consolidated and presented. In this table, we're looking at the occupancy of all 64 nursing homes in Oxfordshire last November. Occupancy or overall is 87%, but it varies in each district. By way of example, I've highlighted the Oxford City in blue. What other colour shall I use? It has a capacity of 708 beds and the occupancy of 82%. Highlighted in yellow is the home with the lowest occupancy in the sample at 17%. That will be a new home that's just recently opened. The final slide deals with the pricing side of the data. The prices here are for beds in the newer homes. Looking at the column on the right, the prices range from £670 to £2,000. Highlighted in blue on the bottom right is the percentage difference between the average of the lower and higher fees. It shows us there's a 34% difference between the fees. Part of the difference will be due to homes providing different levels of care, but the larger part is because homes are also looking after local authority funded residents who are paying less. What do we learn from this data? Finally, there's no link between pricing and occupancy. Less expensive homes that are reliant largely on local authority placements might have lower occupancy for a number of reasons, and more expensive homes providing a higher standard of care can often be full. Secondly, the average occupancy in care homes over the last 5 years is around 90%. That translates into 500 empty beds available at any time in the county. Homes are not responsible for bed blocking. We know that from publicly available accounts published by the Charity Commission that the cost of providing care in a specialist nursing home in Oxfordshire was around £1,000 per week in 2018. The local authority target band today offered in Oxfordshire is £824 per week. So a home will lose £176 per resident per week for every local authority funded client he looks after. With so many empty beds, the local authority will have plenty of opportunity to try and buy capacity at or below cost. In some cases, it will succeed. But our data also shows that many providers have learned from the difficulties of others, such as Southern Cross, and are successfully getting the funding they need, not just from the NHS continuing care, but also from local authorities. What does this data tell us for the long-term future? The market will be polarized. Self-funders want the best for my mum. They can afford it because in most cases they're using the proceeds from house sales to pay for the care, and they rightly expect the care to be first class. Local authorities want the best value they can get. The aspirations of these two customer groups are simply incompatible. Local authorities will use long-term contracts and not-for-profit organisations to provide themselves with a reliable source of capacity. And some are introducing commoditised auction systems to access the marginal capacity in the independent sector. The terms and conditions imposed on providers by the NHS and local authorities lack an effective review clause. That needs to change. To mitigate the risks that downward pressure puts on the standards of care, local authorities and some CGGs are developing their own inspection systems. Homes which cross-subsidise will eventually lose competitiveness as they cannot deliver value for money to self-funders. I wonder if the Competition and Markets Authority will eventually address this. One other lesson that we all learned long ago is confirmed in the data, and that is the vital importance of attracting and retaining a good manager for the home. They make all the difference. I'll stop there.
Thank you very much indeed, George. I think just in terms of outlook, your concern is around local authorities continuing to contract below the cost of care, compounded by potentially an increase in vacancies. This is obviously a very good segue to Kathy, who is actually involved in Berkshire, but also in the ICS that includes Oxfordshire. So as the purchaser of these services, I think it's in terms of the outlook here, Kathy, it'd be very good to hear from you what your perspective is. So hopefully your face is up there and you're off mute, and over to you, Kathy.
Okay, thank you. I don't know if you've got my slide as well, but I think my first point on my slide was actually about the opportunity to build on the foundations of integrated care systems. I work in the west of Berkshire with 3 unitary authorities, and together with the CCG and our local providers, we have formed a Wave 1 integrated care system. We were one of the first group of 10. We've subsequently become part of the much larger Buckinghamshire, Oxfordshire and Berkshire West ICS, but we operate very much as a strong place within that wider ICS. And those foundations have been really important to us in working together through the COVID crisis. I think I'd really like to reiterate a lot of what colleagues have said about the opportunity to really turn the system on its head. We also had the opportunity to be part of a national programme to establish population health management in our patch, and we've done that working through the national programme sponsored by NHS England, and we have got integrated records through our Connected Care programme so that we can see who is involved in each individual's care, and the data that is available about those individuals from multiple sources then helps to inform our stratification of risk and our understanding of need in our system. And we've tried to use that in a number of ways. We've tried to use it to identify vulnerable people in our communities that would warrant multidisciplinary working. And we've also tried to use it at a macro level to tell us which parts of our system, which care pathways in our system are not working as well, so that we can take a service redesign or transformation approach across the whole service or care line. So I would strongly endorse what people are saying, that this really provides us with an opportunity to create the kind of transformation that's now required. People have talked about the dialogue being very NHS centric, and I absolutely recognise and support that. But I would say that even within the NHS, it's actually a hospital-centric dialogue, and there's not the recognition of the role of community, primary and mental health services in the same order as there has been of some of the acute hospital settings. That's coming, and we're seeing that balance being redressed. But even so, I would say there's still a bias, an inherent bias in the NHS towards hospital care. So I completely endorse what others have said about needing a much more rounded view and a real understanding of the connectivity between health and social care, and the messages to the public about that. We still find, I'm sure you do too, that lots of people don't understand the difference between the NHS and social care until they come to experience it themselves for either their older relatives or themselves directly. And there's still confusion about the respective roles of health and social care in the minds of the public. So I think the action plan that came out yesterday and the messaging around the equal placing of care in the NHS is going to be really, really important. So certainly building on the foundations of the integrated care system, absolutely essential, and using population health management as the tool to reshape the health and social care system locally. I've already covered it, and many of you have spoken about this, but the absolute imperative of tackling the inequity between health and social care. We have seen differential approaches to the delivery of PPE, to the social care sector, differential approaches to staff testing, to the social care sector. In my patch, we've been providing staff testing to social care through our own arrangements. We've also been providing mutual aid on PPE, but we are now collectively across our system running dry on PPE, and it's been extremely challenging. I think the other problem that we faced is, somebody talked about the plethora of quangos. I would absolutely endorse that, and I do hope we've seen NHS improvement and NHSE come closer together. I would like to see a similar approach with Health Education England and Public Health England being much more closely integrated, so that we have at least one entity with which to deal. And I think some of the messaging has been a problem. So we've had guidance and messaging coming out either through the emergency planning and resilience line, through local resilience forums, or we've had messaging coming down the normal chain of command in the NHS, from regional directors through to ICS leads and chief execs in the NHS. And then we've had parallel and potentially different messages coming out to colleagues in local government. And that has been a real problem. We've had a disconnect in the timing of guidance. So we've had guidance about things like verification of death and deathtification coming down the NHS route, but not coming to social care at the same time, and causing problems in implementation and delivery. So certainly something about much more coherent messaging would be a big takeaway. Supporting, developing and valuing the social care sector, I've said workforce, but really the sector, I think is really one of the messages that we've all reiterated throughout this, and we've absolutely got to get that right and get that properly framed within the public mind. You mentioned, Henry, that I talked about the home first issue, I think there's been a really valuable role for care homes, which we've already described in the previous discussion. And there's certainly been an opportunity to mobilise capacity in care homes quickly, because we've either been able to open up empty wings or mobilise available capacity quickly. My concern was that some of those individuals that have gone that route may have been able to go home first. And the concern that there may have been, for the sake of speed, people being routed to the wrong care setting, and whether that has an overall impact on their requirement for care as they move through the system. To be fair, I think we've kept that flow going and people have moved on from those step down or interim placements. But there's something for me about how do we maintain a home first philosophy throughout the COVID response. People have mentioned as well how our own staff, but also families and communities have really mobilised. And I think that's something to capture and harness. We see waves of this volunteering spirit in our country. We saw it with the Olympic Games, where we had all the game makers who volunteered. And we're seeing a similar approach with volunteering now, either through the national scheme that people have signed up to, or more locally through our local voluntary sector, or just through villages and towns organising themselves around volunteering. And I wonder how we would sustain that and how we would enable people to continue to make that commitment. There's clearly the motivation and the desire to do that. How do we capitalise on that and sustain that going forward? I agree wholeheartedly that we should look at how the changes that have been made through this process. I think particularly the way we've been able to oil the wheels around discharge and whether or not that can become the new norm. I'm interested in what social care colleagues think about the Care Act easements and the discharge of people prior to some of the more in-depth assessments that would historically have taken place prior to discharge or at discharge, and the extent to which that's helpful or unhelpful. It seems to me that it will get people to the right destination to meet their needs more rapidly, and therefore avoid the issue of people decompensating in hospital and having higher care needs when they are eventually discharged. So I'm interested to know whether colleagues find that helpful. I also support the ideas that have been put forward around block purchasing. That's something in the NHS that we do for our community service. So we block purchase community hospitals and the beds that are in them. We block purchase district nursing services on the understanding that inevitably year on year, the volume of activity is pretty consistent with an uplift for growth. And therefore over time and over a large scale, one could have a reasonable view about the volume of activity, and therefore the efficiency of block purchasing outweighs any benefits of spot purchasing. And obviously within that service, one expects the service provider to deliver a personalised approach to delivery of care. So I'm interested really in what colleagues in the social care sector think about the ability to maintain some of these changes as we take the long view.
Brilliant, Kathy, thank you very much indeed for that. I actually think we're getting some common themes that are coming out here. So in terms of the outlook and the long term, what I was hearing from you is the need for a coherent chain of command, which ties in with what Martin was saying around the number of quangos and three-letter abbreviations out there. The concept of population health management, which is the second time that's come up, and the need for integration, not just discharge, but the right setting. So in some ways, these are things we know about anyway. It's what everyone's talking about, but hopefully there is, what James said very neatly, was an acceleration of some of these trends, that there's an impetus now to actually implement them. And then the other one was the equality of treatment and perception of social care and social carers compared to more clinically focused services like hospitals. So it's that classic thing about it's not low skill or low pay. It's a high skill, high intensity, high stress job, and just looking at someone's salary as a reference point is not the right way of doing it. So I think on that, I'm now going to turn to Ian as by no means the least important, but the last speaker on our panel. We have got a stack of questions on Slido, So what we're going to do is probably extend this by 10 minutes just to try and get through some of those. But I will allow Ian to cover off his perspective as Director of Adult Social Care for Hertfordshire and give his take on this. Ian, over to you.
Thanks, Henry. A few comments from me. I'm aware of some issues that people have raised already about local authorities and the grant monies that are or aren't being passed on in local areas. So I thought I'd just start by giving a perspective on what I think my responsibilities are as director in Hertfordshire and then what we've done about it. So number one, as soon as the grant monies were announced, I considered it my responsibility to make fast decisions about how that money will get spent. And indeed, I actually invoked the County Council's emergency powers in order to commit money before we even knew how much money Hertfordshire was going to get. I thought it was our responsibility to provide some certainty to our care provider market about where the money should be directed. And I know that won't have happened everywhere, and indeed people said, somebody said earlier on 50% of councils haven't yet decided. I would urge you to either write to your director or your cabinet members, because some transparent decision making has got to happen about that grant, and that should be in the public domain. I should caveat it by saying the grant was not only provided for adult social care, it was for all council expenditure that was affected by COVID, but nevertheless, adult social care should be the majority of that spend. Other duties on a director, I think, to encourage mutual aid, and that's not only about PPE, but it is about sharing staff, where one provider is more adversely affected by the other. Obviously, that can only be done by agreement and good partnership, but I think that's a responsibility on me as well. To interpret national guidance, to consider schemes where it will be a good thing to do it once for your area, not multiple times, like recruitment or buying PPE. To have a good interface with the NHS and interpret the new guidance and act so that people are leaving hospital as quickly but safely as possible. And that's not only safety for them, but safety for all the staff in the setting that they're going back to. To link with the local resilience forums, they're generally on a county or council-wide basis, and they're considering the much wider response than just adult social care, but to link in with that's a key thing, providing advice, keeping members on board, and crucially, the easements that were just mentioned, the legislation provides some quite detailed and considered governance about how those easements may be brought into place. And to my knowledge, only one council in the country has applied so far to implement those easements. So it's not something that care providers can do unilaterally, or actually councils can do. We must apply to make those easements part of the working temporarily in that council's area. What have Hertfordshire done very quickly? Set up a provider hub with our local care provider association. So if there's a problem with PPE, understanding the guidance, wanting more recruitment services, wanting to know how to interpret any of the stuff that's coming out on the news or from the local council, that's our central hub. And so it's a website, a phone line, and daily emails are going out. And so we're filling that information vacuum for care providers, and it's been much appreciated. We've pooled our money with the NHS, and we bought over 400 care home beds in Hertfordshire. And for me, the buying of that was twofold. One was to release capacity for the NHS. And actually, we've used the beds for non-COVID-19 patients, not for COVID in the main, in the vast majority. Very occasionally we have, but mainly non-COVID patients. So our hospitals are operating at between 50 and 60% occupancy, leaving much more room for people that might need acute care. But the second reason was we did fear that care homes would bear a brunt to this right at the start. The most vulnerable are very sadly going to pass away with COVID if it happens to get into a home. And so it felt that spending our money in that place would also aid the sustainability of the care sector. And the NHS are able to write that check. So that felt like two reasons why we should block book and make sure that that service was widely available to people. We have done a lot of work on PPE and testing. We do have a warehouse in Hertfordshire, so we've been buying from international markets and sharing that with our care providers. And we did get in on the testing regime a few days earlier than most other councils because of our relationships with the NHS. but I just make one or two remarks about the future, because that's what our talk was ostensibly about. I do think there's a phase for directors to think about sustainability of their local care market now, before the end of this period. We've got 2 or 3 care homes and 1 care provider, home care provider in particular, that I'm worried about, because they have had a significant number of deaths. It will be falling below the occupancy level that George was talking about in his presentation, and the sustainability of those businesses is a concern for me, because we need all the care homes and all the home care that we can buy. So directors need to be considering that now. There's certainly a role for technology and big data, and I'm disappointed in that just before COVID what came about, we were just on the cusp of finding assistive technology solutions that could really help care homes and home care. So for example, an algorithm that using assistive technology could spot someone with a urinary tract infection before they knew they got it themselves. And that kind of intervention and work with the NHS closely and with care providers can prevent hospital admission, but also scale up and down care as people need it really responsively. And I think that's where the care service needs to go in the future. And the final thing I mentioned, I am hopeful that the Secretary of State's announcements yesterday, the great response we've had from the public for the care sector, the clap for carers must remind everyone that that's not just for the NHS, will raise the status of the care sector. The badge will be part of that as well. And so we need to not let all this fall away, and for us to get back to normal, we need to be thinking now, how are we going to capitalise on that now, through recruitment, through volunteering, through keeping stories being fed to the media, so that social care's nature and status gets raised up in the public consciousness.
Very good. Well, look, thank you very much for that, Ian. And I think that, you know, in terms of the themes there, it's a pragmatic use of technology and responsible purchasing of services and allocating people to the right setting, which I think is a continuation of a lot of the themes that we've heard elsewhere. We've got 3 figures of questions waiting to be answered, and I don't, you know, we've run out of time basically. So I'm going to put some of those questions up, and we'll just take a couple of them, but I think it's an opportunity to follow up with some subsequent webinars, and we will see if some of the panelists can come back and join us in a smaller setting on a sort of a one-on-one or a one-on-2 session. So I've just sort of posted a taste of some of the many questions that we've received. And I think actually the first 2 are sort of thematically very much linked to what we've been hearing. We've had Pete and James on from 2 of the largest providers in care homes and home care. But the question I think a lot of investors will be asking, and a lot of regulators and a lot of purchasers, is who is going to survive and what do those providers look like? In some ways, you know, Pete, you've got a large business that can procure PPE independently of official channels, that has HR teams that can recruit people. And maybe it's very, very different for that long tail of the sector, which are smaller providers who may not be as resilient as the larger providers. So what's the message here? Actually, does scale bring significant benefits, or are people who are smaller operators able to take actions which will allow them to survive this pandemic? Peter, if you've got any thoughts on that. And I'm going to then turn to Julian Evans, who I hope is on the line, who runs the healthcare team at Knight Frank, but has also been speaking to a lot of providers.
So, do you want me to answer, Henry?
Yes, please.
So I do think there's pros and cons for large providers and small providers. In terms of large providers, you can smooth performance across homes and issues across homes, across a portfolio, so you can support a home that has issues with commercial issues and quality issues across a bigger portfolio, not only through financial support, and you can bear that for the time, but also specialist support that can come in from other homes to try and support it. So I do get there's benefits from that. There's also clearly benefits from small homes, which are very much owner operated and supported, with a lot more time can be invested by the senior individuals in the homes. I do think there's been some questions that have come through that have suggested more collaboration with single systems and sharing how people do HR or e-learning or training or care planning, And again, these are things and the time and investment that's required to do that as well as possible in best practice. And we've, again, like the delayed discharge issue, we've been talking about this with regulators and commissioners for some time. And I think, again, one thing that might come out of this is actually we all start collaborating more and get out of our silos and actually partner. Because to me, I think competition is less of an issue than actually working together for best practice and the best interests of all of our residents. And I do think that actually a way forward could be a single national care plan, a single suite of e-learning that we all sign up for, a single way we do regulation and internal inspection. And then we can share that. I'm quite happy to share all of that with any small providers and best practice, because I think we're all in it together. And I do think it doesn't really affect how competitive I am. It's about the staff, the teams, the facilities, and we all do our best to try and work in the market we're in. And so I have a very little issue about sharing stuff. I don't really think I can comment anymore. The one thing is I've got to leave at 11, so I've got another interview, so I can't stay on much longer than that. Thank you.
Well, Pete, that's very helpful. I'm just going to let Chris say something. He's holding his hand up.
Just to say, in the context of that question and others, I think there's a really important link between data and information and the way in which we think about system health and also innovation. I think for data information, I absolutely agree with that point around sharing information and collaboration. It's got to be easy to fill in. It's got to be easy to share, and it's got to be best fit for everyone. Everybody wants a slightly different version of the data for different things, so it's got to be best fit, easy to fill in, and easy to access. And in terms of with that, I think you can get a better understanding of system and population health, and we as regulators and other organisations, I think will therefore we can have a better conversation that mirrors the conversation in the NHS about what the population health needs. And I think with that data and information, we can drive the right conversations with the rest of the system, and we can also see real innovation. And innovation is about using the information and data in a different way. It's also about good conversations, and it's also about trust. I think we've got a role in that. I think others, other commissioners and providers have a role in that as well. But data information with a single view that you can build innovative solutions from, I think, is the key.
Thank you very much, Chris, for that. I think we're so overwhelmed with questions. We'll have to sort of come back to this. But I don't know if Julian Evans is on the line, just to give a perspective from the providers that you've spoken to. Julian, are you there? No, it doesn't sound like you are. Well, look, I think we need to wrap up because we're out of time. I'd just like to say thank you very much indeed to all the panelists who've joined us today. Really appreciate their time and their insights. I think we've started to touch on a really interesting topic, which is what we can do with this pandemic that is for the good of the system of health and care. And I think in some ways it is the nudge that could potentially generate some really, really good outcomes for the people who are providing that care and the service users who are receiving it. So thank you all very much indeed. This is the first of a series of webinars. Our next one is on the 28th of April, which is around workforce. And we will take all the questions that you've got and drill down on the ones that are relevant to that. And I think we'll also have webinars in our series. We're putting them together on technology, on care provision around the different markets. I think what you've seen today is that home care is not the same as care homes, it's not the same as hospitals. But just to wrap up, and thank you all very much indeed. We've had nearly 700 people listening. We will post this on YouTube for people who'd like to view the video, and very much look forward to seeing you at the next one. Bye.